All right. Thank you, everyone, again for joining us today for what is Hospice, the first event in our At Home with Hospice series. We are so pleased to have Dr. Kevin Keck of Suncrest Care here with us today, and it's my pleasure to introduce him to you. Dr. Keck is the medical director for Suncrest Hospice. He's a hospice and palliative care physician and has been doing hospice work for over 12 years. He has extensive experience caring for patients with chronic illnesses in hospital and clinical settings. And he's also worked in the emergency department, ICU, hospital wards, and has created population management programs. He's a published author, and we're so pleased to learn from him today. Dr. Keck, I'm going to turn it over to you.
Great. Okay. I'm Dr. Keck. What we're going to do today is give an overview of what hospice is all about. And I call this a hospice primer. And the overtitle is Aging in Place. Next slide. So hospice care is an extremely comprehensive program provided by the federal government. The concept was started in England, and it came to the United States about 40 years ago. What hospice care is all about is care for a patient who is at the end of his or her life. The care looks like this. It's a team approach. It isn't just one individual, it's a team. And the team works together. There's an RN case manager. We have a chaplain. We have a social worker, a physician, and we have home health aides. And what we do is we care for the whole patient. Next slide. We address 4 domains of suffering, and this has been learned at the end of life, that these are the domains that cause burdens of suffering, and so we address each of them. The first is physical, and I participate a lot in that, and this is pain, shortness of breath, things like that. Second is spiritual. There's a lot of spiritual work that's done at the end of life. Sometimes patients are lapsed from their church. Sometimes they have no organized spiritual group, or they're in an organized spiritual group. And we take this across the spectrum. We deal with psychological symptoms. There's a lot of that happens at the end of life. There is anxiety, there's depression, there is agitation and hallucinations. We call that psychosis. So that happens. And then there's social issues. And the social issues tend to be in financial areas or family dynamics. Next slide. Now, the benefit is resource rich. It's the most that Medicare offers outside of the hospital. There's lots of team member visits. Patients are well known to the team. We have 24/7 availability. And let me just point out that if our patient develops a bladder infection Friday at 6 p.m., we can handle it that night. If our patient becomes agitated Saturday at 3 a.m., we can take care of it right then and there. We have a fast response, and we're available by phone and office and visits if needed at any time, and we can get there quickly. And what we do creates many fewer burdens of suffering. And frequently we'll get patients on hospice, they're not doing well, and we relieve that. Okay, next slide. Patients can and do get better. And we know that because when we make them comfortable, the burdens of suffering are much less. And so medical conditions are detected early. Bladder infections, wounds, pneumonia, constipation, delirium, pain. We're expert in all of those. Care is very attentive. We do this care at the care setting, so there are no trips to the hospital. When our patients die, there's grief care. We are experts in grief. This all came from Dame Cicely Saunders, who was a nurse in England in the 60s. And she felt that the dying patients were not well cared for. So she started the hospice movement. She got blown off by her colleagues, so she became a physician, and then they couldn't blow her off. One thing I like about her is every day, they did this as an inpatient, every day at 5 o'clock, everybody had an alcohol beverage to calm everybody down from the events of the day. Next slide. So hospice eligibility is that a physician, me, guesses that the prognosis is 6 months or less. In other words, do I think the patient will die within 6 months? Excuse me. I apologize for that. Common conditions that will lead to that opinion include metastatic cancer. We see that frequently. Organ failure, like heart failure, we're admitting a patient today with that. Respiratory failure, these are patients that have lung disease of various types, including chronic obstructive pulmonary disease, and we help them. We have a lot of neurologic conditions, dementia, Alzheimer's disease, multiple sclerosis, Parkinson's disease. We take care of that. When the kidneys fail, then we can take our patients with renal failure, liver failure, unexplained weight loss. So it can be really anything that leads to me or the hospice medical director writing down that I think the prognosis is 6 months or less. Next slide. All right, so how do you pick that out? How do you know? One key survey question is, would you be surprised if this person died in the next year? That is really highly sensitive. So if the answer to that question is yes, then hospice should be something thought about and discussed. Things to look for are trips to the hospital and emergency department. We admitted a patient yesterday who had several falls in the last 2 weeks. If they're in the hospital for any reason, respiratory failure or infection, those things happen at the end of life. We look at the decline of oral intake, that is eating. And there's a spectrum with this, that can the patient feed him or herself regular food? Can the patient chew and swallow? Is there difficulty with that? Is there difficulty using a spoon? Is the amount of food declining? Is there coughing or choking with eating? Do we need to use a soft chopped or pureed diet? Those are things that we look at. Now, mobility declines are where the patient can walk by themselves, and then there can be a fall, and then the patient has some difficulty walking and needs an assistive device like a walker. Then can the patient stand up from one chair and then walk to the couch? Does the patient need assistance with that? Can the patient no longer walk? Can the patient turn themselves in bed? Cognition declines. This is mental status. And with my own mother, it was hard to pick out because she was right on target as I was speaking with her. But one of the first signs was she could not figure out how to take her medications. And then what happens with those early signs is it progresses. There's short-term memory loss. Long-term memory tends to stay put. Then it can be confusion, hallucinations. There's a whole variety. Weight loss is important. That at the end of life, very commonly we lose weight. So we look at that. Are the clothes fitting looser? Are the pull-ups fitting looser? If you look at the face, does it look thinner? Those are all markers of loss of body mass. When the patient can no longer move in bed because of weakness, then there's risk of breakdown of skin. We see this and we treat it. These are called pressure injuries or bed sores. They usually occur at the sacrum or at the very low part of the back above the buttocks. They can be anywhere there is a bony prominence. Falls. Falls are important because not so much that the patient fell, but it is because they're so weak that they fell. That's the key thing. And oftentimes, the end-of-life process starts with a fall because of the weakness associated with that. And then I put down et cetera, because anything that we can see clinically can be important. Next slide. Okay, so hospice eligibility. I want to point out that this is voluntary. The patient or the patient's agent, healthcare agent, chooses hospice care. It is not a sentence; it's a choice. And the Medicare benefit is very clear. What all hospices provide for the patient. I am with Suncrest Hospice. All other hospices in the area are required to provide the same kind of care. Now, Medicare pays the hospice directly instead of the insurance company. And what that means is hospice pays for all care and medications that are related to the hospice illness, which is just about everything. The medical care, the physician, the nurse, the social worker, the chaplain, all the durable medical equipment, all the medications, those are all paid for. Now, if the patient decides, no, I don't want to do this anymore, I'd like to go see my doctor, that can be done at any time. Once you make the decision to come onto hospice, it is not locked in. You can leave. When patients choose to leave, which is every once in a while, typically they will come back, but they have the right to revoke. And then family has a responsibility for the setting of care. And I want to describe what this is, that the setting of care can be at a home or a board and care, or at a skilled nursing facility if the patient has Medicare, or an assisted living. The activities of daily living are in the setting of care. So that's feeding, bathing, toileting, those things. And then also administration of medication is at the setting of care. So family is responsible for that. So that is understood at the start of care. Next slide. Now, if there's a question, my goodness, is my loved one eligible for hospice? I just don't know. It's hard to tell. I've been doing this for a lot of years, and I have a lot of training, a lot of experience. For me, it sometimes is a challenge to figure out how long this patient is going to live. Usually it's apparent to me, but there's such a thing as a palliative care consult. And the palliative care consult is done by a physician and answers two questions. What is going on and what is going to happen? I'll just give you a story that I was in the emergency room and a woman came in and she was not doing well. She was in a wheelchair. She had some bed sores, and I walked up and said, can I talk to you about what's going on here? And it was a very welcome visit. And the son thanked me because he'd been going around from doctor to doctor trying to get an answer of what is going on, and it can be really hard to do, particularly with a cancer doctor. Then what is going to happen? The explanation of with these things that are going on, here's what you can look forward to. And when I do this, I talk about, would you like me to tell you how long I think you're going to live? And if I get permission, then I will say that. And when I say that, that's usually very helpful in determining setting of care and what to do. The prognosis is what we call that, is how long do I think you're going to live? And that's called the prognosis. Next slide. All right, so hospice treatment's physical, and this mainly is what I do in teaming with the RNs. We know that at end of life, the large majority of patients will have pain. The cause of this is the lack of mobility or the underlying illness. Think of sitting in the middle seat, flying from here to London, what that would feel like when you got off the airplane. And that's what our patients feel like, that they can't move and they get stiff and sore. There is delirium. As the brain declines, the brain will make up things when it doesn't understand, and this is called delirium. And what that can look like is the member or the patient seeing their mother sitting in the room next to them, or the dog that has been dead for 30 years. They will see things like that, or they'll get agitated. Wounds, there's there are effective therapies for wounds. They need to be handled, but wounds do happen. Sometimes they can get healed, sometimes they can't. Shortness of breath, this can happen with lung failure, heart failure, pneumonia, and we can treat that very effectively. Constipation is very common. If a person is constipated and it's been more than 5 days, that in itself can cause delirium and hallucination. So we take care of that. Edema is swelling. Usually it is in the feet, ankles, legs. We're very effective at treating that. Rashes occur, and what are these? Is it a allergy? Is it shingles? Is it a drug reaction? We can take care of that. If our patients fall and get a fracture, we do the value judgment, whether it's worth it to put the patient through the turmoil of a surgical repair, or should we care for the patient at the care setting and reduce suffering on balance, et cetera. Keep going. All right, so we're very good at treating pain in extremis. This oftentimes happens just before death, and it's called the preterminal delirium, or preterminal pain. And this can be excruciating, and we have very effective means of caring for that. Same thing with delirium. We see this commonly at the very end, but not necessarily. We can calm that down. It it usually occurs at night when our patients or the hospice patient loses the bearings of being able to see what's around them, and that can create delirium. So we're very good at treating that at 3 o'clock in the morning. Shortness of breath, dyspnea means shortness of breath, and if the patient's really struggling, we can relieve that. If the patient has poor response to the usual medications, we can reset the brain. And what that means is we can make the patient sleep, then they wake up and the brain is back to where it was. Terminal delirium, I've talked about. This can be dramatic. Everybody is fretting with these types of symptoms, and what hospice can do is handle this at the place of care rather than taking the patient to the emergency room. Okay, next slide. Now, social. There's a lot of social issues at the end of life, and family dynamics is an important one. It's interesting to watch this of which daughter is not speaking to mom, or did dad abuse the children, or is the brother that's been distant from the family now wants to get back involved. But there's lots of dynamics that go on, and we do our best to help with that, with reconciliations. And oftentimes there's an estrangement, and we work with the families, and then before death, then the two family members can reconcile and be at peace. There are financial pickles, and where this comes from is the care settings can be expensive. It's a fact of life, which is unfortunate. To have home care with family doing it is the least expensive, but it takes at least two people, preferably four, to care for the patient, and then they cannot work their regular jobs. If there's a board and care, which provides excellent care, they range from $5,000 to $10,000 a month, and then assisted living is about the same range, maybe more. And then skilled nursing facilities are prohibitively expensive, $12,000 to $15,000 a month, unless Medi-Cal is paying for it. We help with the funeral arrangements, and we help with setting of care management. We have a daughter of a woman who's really upset with the care setting, and we're helping her change care settings. Okay, next. Okay, psychologic, I help a lot here, and our patients at the end of life have a lot of these, and depression is common. Hallmark of depression is lack of energy. That's the hallmark. So if we see that and the other markers of depression, we can treat that effectively. Anxiety, common, we can treat that effectively. A lot of fretting that goes on with loss of many of life factors, like you can't drive anymore, you can't go to the store, you have to sit down, you're hurt. That creates anxiety. A lot of psychosis. Psychosis is loss of touch with reality, manifested by agitation. There can be aggressive behaviors where the patient will strike out at caregivers. This is related to fear. We know that, and we know how to calm the fear center so the patient feels comfortable. We do not make our patients zombies. What we do is get rid of the fear. Next slide. Spiritual care done by chaplains. We reconnect our patients with their religious background. We help them connect with God. We do life histories. One thing that is very well received is called veterans pinning. And this is led by the chaplain, where a veteran, we did this last week with a lieutenant colonel who was dying, and we had a ceremony which was very well received, and that's part of spiritual care. Next slide. All right, now grief is really, really important. And what normal grief looks like is a 6-month process. When my mother died, it took 6 months for me to get over it. And that's with everything up front understood and normal. Complicated grief is different. And when there's complicated grief, there's some reason. And was the death tortuous? Was the death painful? Was there an estrangement that didn't get resolved? And was it death of a child? These are all risk factors for complicated grief. To address this up front, we advise that families say this to each other, and this has been studied and it works, that we ask both the patient and the family to say, "I love you, thank you, goodbye." And those are the goodbye statements. And then there's the reconciliation statements. "Please forgive me, I forgive you." And we work up front with anticipated complicated grief. And then when the patient does die, we plan the grief strategy so that the loved ones feel better. And this with hospice goes on for over a year. It's actually 13 months. Next slide. All right, now this is about Suncrest Hospice, and just a couple things about us. That our nurses have smaller caseloads. We have physician availability 24/7, and we can do same-day intake. That's important because oftentimes the decision to do hospice is made at times that look like Friday at 5 o'clock or Tuesday at 3 p.m. and intake needs to be done today, and we're able to do that. We also have a music therapist on staff, and what she does is provide music therapy using genres that the patient likes, be it the Beatles or gospel or whatever. She can do that. And I think that's my last slide. Next slide. Yeah, all right. So I am ready to look at questions. And I'm going to click on chat, right, Simone?
Yeah, so Dr. Keck, I've been monitoring the chat for you during your presentation, and we do have a couple of questions to get us started. Thank you so much for all of this information. The first question that came in was, can you explain the differences among hospice care, palliative care, and comfort care, which is a term for this person that was used in the memory care facility where her mother was placed?
Sure. Yeah. All right. Okay. So what this looks like is there's a spectrum of care that goes on from birth to death. And what we're all mostly used to is regular patient care. And what that looks like is if I have high blood pressure, I can go to my doctor and get treated for high blood pressure. If my child breaks her fibula, leg bone, I can take her to the doctor and get a cast put on. Now, as we get older and develop chronic conditions, such as heart failure, diabetes, liver failure, lung failure, then regular care becomes kind of tricky. And so palliative care is a branch of medicine where there's an overarching hand that takes a look at what's going on, making sure that it's all going okay. And an example of that there was a group of lung cancer patients, and at diagnosis, they were divided into two groups. And one group had regular care for their lung cancer, and then the second group at the beginning of the course of therapy had regular care for their lung cancer plus palliative care. So somebody was watching, making sure that, did you get your pain medications? Do you know how to get to your doctor? Do you know how to call your doctor? Do you know how to take your medications? Those things were addressed. It turns out the group that had the palliative care, the overarching manager, if you will, lived a lot longer than the regular care patients. So palliative care, what it does is it manages usually chronic conditions, so that there's an overarching hand to make sure that things get done according to what the doctor wants. Now, hospice care is care that is when the patient and family agree that they want it, and there's a terminal illness. So if a patient comes in with heart failure and has some difficulty breathing and has some pain in the joints from arthritis, all those things are cared for. The breathing is cared for, the heart failure is cared for, the joint pain is cared for. If there's a stomach ache, that's cared for. If there's trouble sleeping, that's cared for. So all conditions causing a burden of suffering are cared for. At the very end of life, when the patient is entering a condition called transition, and what that looks like is the patient says, I don't want to do any of this regular stuff anymore. Just make me comfortable. We had a patient like this yesterday with heart failure that we treated, and he wanted to die, and he died very comfortably because his life was just so miserable. He asked for comfort care. So this would be a patient with cancer that can no longer eat and is lethargic or sleeping or in a coma, or the patient's having trouble breathing and doesn't want to do that anymore. So comfort care focuses only on pain, shortness of breath, delirium, anxiety, so that these symptoms of dying are relieved, and then all other cares stop. So comfort care is done at the very end of life. When people die, 8 times out of 10, the dying process goes on for several days, and that's called transition. 2 times out of 10, there's what we call sudden death, and that would be like a heart attack or a stroke. And sudden death means the patient's doing baseline or fine, gets sick, and then dies within 24 hours. That's a minority. Usually the death process lasts several days. And then during this time, the treatment of choice is the comfort care.
Okay, great. Thank you, Dr. Keck. Just to reiterate, to make sure that I'm understanding the differences that you've outlined, along this spectrum, palliative care is really about sort of managing chronic conditions.
Yes.
Hospice care is about providing care at the end of life, and comfort care is about specific interventions to make people comfortable as they're transitioning.
Correct. And
Okay.
one little comment about hospice care is the goal of hospice care is comfort. The goal of hospice care is not how long can we make this patient live.
Right.
Yeah.
Right.
So and an example of that would be if a patient is very sick and they get pneumonia, do we treat that with an antibiotic, or do we treat that with a medication that relieves shortness of breath? And that would be an example of the goal is comfort and not prolonging life.
Thank you for that. We had a couple of questions that were clarifying questions related to the response that you just gave. So I'll start with those and then I'll circle back to ones that came in a little earlier. One individual is wondering, does Medicare pay for skilled nursing at the end of life?
Yeah, that's an excellent question. Skilled nursing, let's see, payment for skilled nursing at the end of life is a Medicare benefit as long as the patient is making progress. If the patient is on hospice, then by definition, the patient is not making progress. Medicare does not pay for that. Now, if a patient has Medi-Cal and Medicare, that's usually what it is. But if the patient has Medi-Cal, that can pay for a setting of care in a skilled nursing facility as long as there's a skilled nursing need, which is pretty easy to find, such as a bed sore or a broken bone or breathing treatments. Those would be examples. So skilled nursing facilities are there. We have patients there rarely because the patient has to have both Medi-Cal and Medicare. Sometimes Medi-Cal alone, but that's what the rules are.
And if a person who is on Medicare elects to go on hospice but comes off of hospice, does that Medicare benefit for skilled nursing resume?
Yes, it does. So what happens is the benefit goes back to the Medicare benefit, and there's different kinds of Medicare, and there's straight Medicare with the 20% coinsurance, and then there's Medicare Advantage, and these are managed programs. But by and large, the benefits are the same when the patient's on hospice. When they go off hospice, they go back to where they were, straight Medicare, maybe with a supplemental policy, or Medicare Advantage, where all things are cared for by the HMO.
Great. I'm going to circle back now to some questions that were posed a little earlier. This individual shares that her father had pneumonia, several other infections when he was in hospice he was in hospice for about 6 months. Under hospice care, he was dismissed several weeks ago because it was determined that he no longer had the diagnosis of death within 6 months.
Right.
And so the VA stepped in and actually got her father back onto hospice, a hospice plan that's not covered by Medicare. In the last several weeks, this individual's father, who has dementia and is in his 90s, has lost the use of his legs and can't communicate. How can hospice, the question this person has is, how can hospice release patients like her father when they know that there's no chance of them improving?
Right. Yeah. And so the hospice benefit is, let's see, hospice is done in benefit periods. And there's the first period and the second period, and that equals 6 months. And then every benefit period after that is 2 months. Now, every patient every 2 weeks is discussed by the entire team. Now, Medicare rules, it's not hospice, but it's Medicare rules, say that if the patient after the second benefit period, after 6 months, is not declining, so that the medical director, me, can write prognosis is less than 6 months, then Medicare requires that we discharge the patient for no longer terminally ill or extended prognosis. Now, what can happen with that is some months or years later, when the patient is declining, we can take them back. But this is a Medicare rule that they're very strict with. Now, the VA in this setting stepped up, and that's a good thing. And they want to take care of their veterans, but that's where the patient graduation comes from. When we do that here at Suncrest, we offer palliative care to the family to take care of the patient, and so we try to do a warm handoff that way. Oftentimes, families will decline that, but that's how the system works. The other thing how the system works is if the patient is under age 65 and does not have Medicare, the hospice benefits tend to be exactly the same because the insurances for people who are under 65 want to give the same benefits as what Medicare does. Medicare sets the standard of what care should look like, but the situation that's being described is the team felt that this was a prognosis longer than 6 months, and therefore Medicare wants us to discharge the patient.
Thank you for clarifying that situation for us and giving us a better picture of kind of the behind the scenes, Doctor. Another question that came through, Parkinson's is listed as a reason for hospice, but is Parkinson's alone a reason, or does it need to be Parkinson's disease accompanied by unexplained weight loss, pneumonia, etc.?
Yeah, excellent question. You guys are asking great questions. Thank you. I'm enjoying this. So a Parkinson's patient has difficulty with Parkinson's disease, movement, posture, tremor, those things. Patients can do very well for many years. Think of the actor Michael J. Fox, who has had Parkinson's for many years. Now, at the end of the disease process, there usually is development of dementia. There's changes in eating patterns. There's falls. Sometimes the anti-Parkinson's medications are no longer effective. And it fits in that earlier part of my talk of the things that count to determine if a patient has a 6-month process or less. So for a Parkinson's patient to be on hospice, then we look for those other markers demonstrating that prognosis is 6 months or less. Now, during this time, we take full care of the Parkinson's, and there can be a special dementia with that has hallucinations, but that we can make our Parkinson's patients feel very comfortable.
Thank you. Another question that came through was specifically about groups, online groups that deal with anticipatory grief. So one, Dr. Keck, can you define what anticipatory grief is for us? And two, do you have any recommendations for groups through Suncrest or in the greater Sacramento region that deal specifically with anticipatory grief?
Right. And anticipatory grief is taking a look at the clinical setting and determining if this is high, medium, or low risk for grief issues. So that we try to anticipate ahead of time. And like I said, we discuss every patient every 2 weeks, and the chaplain weighs in, the social worker weighs in, the RN case manager weighs in. We can look at the notes of the home health aide worker who I should say does baths and massage, very well received. So if we can see things aren't going so well, there's financial issues. The grandson has depleted half of the bank account, or the son is very upset that mom is dying, or the patient may have some kind of a mutilation from multiple bed sores. We can see this coming, and what we do is take steps to set up the grief process ahead of time, and that's where those 5 statements come from. That has been scientifically studied, and if those 5 things are said, I love you, thank you, goodbye, forgive me, I forgive you, that helps in the grief process. Now, when we know it's going to be rough, then we'll identify that when the patient dies as a high risk grief patient, and then we'll take steps accordingly. As far as groups in town, I'm not familiar with them. However, the chaplain and social worker can help in that setting. That's out of my area specifically. It's grief is managed by the experts, social worker and chaplain, and then they might be able to help with the groups. That occurs on occasion.
Great, thank you. In the chat, someone mentioned that Oro Cares has a group every Monday night online that can deal or that deals with anticipatory grief. I know that Del Oro maintains listings of local support groups that focus on grief as well. So in the follow-up, I can provide some suggestions for support groups in Sacramento. I did want to highlight that later on in our series at Home with Hospice on Thursday, May 25th, we'll actually hear from one of the social workers at Suncrest Care about anticipatory and complicated grief. So some of the terms that Dr. Keck used today, and I wanted to underscore that anticipatory grief for the caregiver typically manifests as this feeling of sadness, of loss before someone passes away. And it's likely due to a loss of functionality in the care receiver, as well as the caregiver's changes and expectations and transitions. So that grief happens before someone dies, but it's very real for the caregiver. And it sounds like Dr. Keck kind of outlined that the hospice team takes that into consideration when they're helping a family, that the caregiver is probably negotiating a lot of grief during this process of transition as well.
Absolutely, and it's all caregivers. And yeah. We had at a facility, there was a favorite patient on hospice and died, and the staff were so distraught that we sent out a chaplain to work with them because the staff are distraught. When it's family members caring for the patient at death, they're exhausted. To take care of a patient at home, you do the math, 168 hours a week divided by 4, that's 4 full-time jobs. And usually families do this with fewer people. So they're exhausted, and they watch their loved one decline, and they know they're not going to get better. That's really, really hard. So that's where we can help to support them in this setting. And the settings that we get are myriad, and we take them as they come and understand what the family's been through, and then approach accordingly.
Excellent. So we're coming up on the top of the hour, and I have a few more questions for you. Thank you. We did get a question about a specific or about an anticipatory group. grief group, and YOLO Cares provides one on Monday nights. Information for that is in the chat. Dr. Keck, what does in extremis mean? And
I'm sorry. I'm sorry. Yeah, in medical school, you learn Latin. That's a Latin word. And you can substitute the word extreme. And, I'll just give you a couple examples I had a patient who was in terminal delirium, and the ball was kind of dropped. The patient was sick, and it was a known Friday issue. The case got handed to the weekend worker. The patient was standing in his room in his diaper, refusing it to be changed. So he had a couple of bowel movements in there, and nobody could touch him. He was swinging. What we did with that is there was a worker that was trusted, and we got her on her day off to come in, and the patient accepted her giving him some medications, and so we used what I would call giant doses of medication to calm him down. We did, and he died comfortably. Another example of pain in extremis is I was taking care of a young man who was an amphetamine addict and had a very sick bowel. He had created areas of his bowel that had died and had turned into abscesses, and he was in agony. And so what I did is I gave enough morphine. Actually, I think we're using Dilaudid on that one. Anyway, we gave him enough so that he died peacefully. So in extremis means extreme, and we have seen it all, and we know how to take care of it. So in extremis is just Latin for this is as bad as it gets.
Okay, thank you for that clarification. Another question that came in: how does hospice look differently in different care settings? You mentioned that hospice can be elected in home, in a assisted living facility. How does it kind of operate differently in different care settings?
It turns out that the care given by the team has to be the same regardless of the setting. So if it's home, if it's board and care, if it's skilled nursing or assisted living, the care has to look the same. The only difference is the care settings provide the activities of daily living a little differently. At home, for example, the diaper changes tend to be more attentive than they are at an assisted living facility, for example. And then on the other hand, the medication administration tends to be much more precise if the patient's in assisted living or a board and care than at home. But the difference is the difference between the different caretakers. Is it family? Is it a med technician? This is a person that passes the medications at a facility. Is there an RN? There's a spectrum of abilities in the caregivers, and that therein gives some differences. And if we find that things aren't quite up to par, we work with the family. Like we had a family that had rats, and we got some rat traps, so the rats are no longer in with the patient. So we help with the care setting doing things like that.
Okay. One last question for you here. In numbers, what percentage of what percentage of aging baby boomers plan to die at home?
Yeah, I actually know the answer to that. When asked, the vast majority great majority of people want to die at home.
Mhm.
And that's been measured. It's a given. There are some cultural subsets that folks from China sometimes want their loved one not to die in home, and that's a cultural thing. But when asked, the vast majority of people want to die at home in their own bed.
Okay. There's another question that's coming through, Dr. Keck. Where are we going to find medical caregivers going forward in the next 10 years? We know that there's a shortage right now. And we have a population that's aging. So do you have any insight into how?
Yeah, it's this is a cultural thing and an ethnic thing. There are caregivers out there. There's physicians out there. There's nurses out there, and the reality of what's going on is the caregivers in the boards and care usually have an immigration history such as Russia, Fiji, the Caribbean. We see that a lot. The care that they give is excellent. But that's usually where we find our caregivers from those populations. We make sure that the care that is given is what we need, and that is what we find in actuality. But it's a pretty international group that does the actual caregiving, and that's regardless of setting that we see that.
Okay. Thank you for that response. There was a follow-up to your last response about the number of people who would prefer to die at home, or a clarification. This individual wants to know if there's not enough room for, if there are not enough places for dying baby boomers, does this mean that they have to stay at home?
No. Okay, let's talk about economics in America. It turns out that providing care at a board and care facility is a lucrative business. They make money. This is a reality, and for that reason, there are plenty. And with the boomers coming, there will be more. There will be enough. So I don't fear that. And there always will be skilled nursing facilities with the Medicare and Medi-Cal populations, and assisted living facilities. They're profitable. So I do not anticipate there's going to be a lack of care settings for those reasons. It is an economic reality, and the cost of care can be attention getting, but usually families can work things out to get the care they want. And like I said, that's where having a prognosis can be really helpful. I've gotten Dr. Keck, we're going to run out of money in 2 months, and so I say, well, let's do a prognosis, and then when we do that, it turns out everything's going to be fine. They will have enough money. But it's an issue, and this is an issue where our social workers certainly can help.
Thank you so much. Thank you everyone for your questions today. And I just want to give us a sincere thanks to Dr. Keck for this wealth of information, for being a wealth of information, and for answering all of these questions. It's so wonderful to have a doctor in the room and to hear straight from you about hospice and palliative care. In the chat, you're getting some thank yous from participants. I just wanted to highlight that for you. At this point, Dr. Keck, is there anything else that you wanted to add? Any information you wanted to give us about Suncrest?
Sure. Well, we're here and we're happy to answer questions. And like I said, if anybody wants a palliative care consult, then you can call Suncrest Hospice and then present the request, and I can do these. So that's kind of a thing that we can do here.
Excellent. Thank you so much again. For everyone on the call today, I just want to remind you that Del Oro Caregiver Resource Center is also a resource that's available to you during your caregiving journey. And this includes at the end of life for your care receiver. You can see our services on the screen here, our information. Check out our website, which again includes support group listings. So for those of you who are interested in getting some support around grief, including anticipatory grief, please check out our website. And I want to highlight that our At Home with Hospice series will continue next month with a screening of the film Endgame and a discussion about what hospice, palliative care, all of this looks like in people's lives. So we'll get to see it represented in film and talk about it. And we hope you'll sign up and join us in Natomas at the North Natomas Library. With that, one more thank you to Dr. Keck, who, by the way, manufactures his own whiskey.
That's right. Yeah.
I just want to give him a shout out for that. That was one of the first things he told me, and I'm super impressed that he finds the time to do this while he's helping so many people with their end of life. All right. Take care, everybody. We'll see you next time.
Thank you, Simone. Bye-bye, everybody. Bye.